Well, thank you, Ben, and thank you for inviting me out to talk this morning. And what I'm going to talk about is an idea, a mechanism that the Ontario Ministry of Health has come up with about evaluating technology. So I'm going to use our trial, but as well. I think this is really an excellent model that they've come up with where they can actually review a technology before it's introduced into the healthcare system, because as we all know, once you introduce something into the system, it never comes out. So the idea here is that they'll actually evaluate something before they put it in. Now the group that we're working with actually so the group that we're working with actually has done EVAR, and they've done a number of different things like that, usually resulting in a high-level publication. And as well, they've also, the ministry itself, this group responds directly to the minister, and so they can get funding for a procedure very rapidly. So within 2 weeks, actually, the minister has to respond to them. So this is the actual structure, and so a physician or any kind of healthcare provider can actually request a review of a technology. OTAC, which is the committee, is made up of a series of CEOs, lead physicians in the province. They then request a health technology assessment, and that health technology assessment looks at the status of the procedure in the province of Ontario, looks at the cost factors, etc., and within 16 weeks has to complete an assessment. Now, once they go back to OTAC, then OTAC actually says there's enough information for us to make a policy statement, or we need more information. So in our situation, what happened was OTAC said that there wasn't enough data to actually make a definitive statement about the management of BPH in the future in the province of Ontario. So they felt that a research trial was indicated. They then gave PATH and ourselves the resources necessary. And the final step, reviewing the results, is actually this Friday in Toronto, and then they'll make a recommendation to the ministry. Now, some of the information that we found, which was interesting, and it comes into really what we as physicians struggle with every day. As an administrative physician, if I want to change a procedure, and we found this particularly when we went to do the laparoscopic procedures, we could minimize the impact on terms of beds. We could shorten the length of stay, we could cut back on blood loss, cut back on costs, but the costs were in the operating room budget. They weren't actually in the hospital or the perioperative program budget, so it becomes very difficult to shift funds around. So when you drop the cost of TURP by using Greenlight, you decrease the length of stay in hospital, but you have disposables where you've got to send a check out the back door to pay for the disposables. So the translation of funding doesn't really work very well in our system. Similarly, the ministry identified that the costs for drug therapy have ballooned ever since MTOPS, and so consequently they're looking to try and cut back on alpha blockers and 5-ARIs. And what they thought was if there was a less invasive procedure which was more acceptable to the patient might select having have a surgical treatment rather than having rather than continuing on medical therapy. So these are actually the costs, and if you look at it, you can see in 2000 it was about $4 million in medical costs. MTOPS comes in 2003, it jumps to 14 million, and then it goes to 30 million. So there's this rapid increase in the use of medical therapy and the cost. At about the same time, you can see surgical therapy actually dropping in terms of cost. A lot of this actually shows a shortening in the length of stay for TURP, not the actual decrease in the number of procedures. But these are the numbers.
Is that Ontario data?
That's Ontario, yeah. And this is the kind of thing actually by doing this investigation that we learned. Now, the other thing that we learned was that there's been very minimal penetration into the province of Ontario of other procedures. So it's just strictly TURP that was being done. There was a few people who continued doing the VLAP procedure, and there was a few people doing tuna. I think Professor Klotz actually still did. Those are probably his 8 tunas. So we did not have much in the way of minimally invasive procedures in the province of Ontario. And when they actually costed these things out, these are the costs that the ministry figured out in terms of what their cost to do a TURP, their cost to do a Greenlight, and their cost to do combination therapy. So you can see with combination therapy, in 2.5 years, 3.5 years I should say, you've got your money back. So if a patient selects, rather than go on combination therapy, to have a Greenlight, very quickly you get your money back over the 3.5 years. The other thing is that, as we all know, a certain percentage of those patients who go on combination therapy are going to cross over and they're going to have a surgical procedure, so the ministry actually double pays on those patients. So this was obvious. This and the fact that you could save 10,000 bed days a year was very attractive to them to going ahead with evaluating a new procedure. Now, the interesting thing is this paper from Yu et al. In the Journal of Urology is published in 2008, and this is Medicare data. And this Medicare data from the States actually shows what goes on in terms of minimally invasive procedures down there as compared to what we do. And you have to put this in the context that this is at the time where medical therapy is really expanding dramatically. MTOPS, of course, in 2003. And here what you can see is this dramatic increase in the number of minimally invasive procedures in the U.S. So if you look at the microwave procedure, the tuna, and the interstitial laser, which is the laser coagulation, you see these 600% increases in use of these procedures over this period of 5 years. Now, what this actually has to do with is reimbursement. The American government in the early 2000s elected to reimburse in-office procedures very high. So if you actually did a microwave, you got about $4,000. If you went to the hospital and did a TURP, you lost money because you only made $750. So all of these physicians' offices were equipped with tunas, microwaves, interstitial indigo lasers, which are the tabletop diode lasers. And so you saw these dramatic increases in these procedures. Now, when we published our meta-analysis of the data, which was the first step, we used the first step of the process, and we published a meta-analysis in Urology last year. And what we found was that with microwave, tuna, laser coagulation, there were no trials actually that we could say were valid trials to prove that these things should be utilized. And the interesting thing was that the ministry at that point came out and said that if physicians were using microwave, tuna, or interstitial laser in the province of Ontario, they should consider use of other procedures. So they were willing to come out and actually say that there was no data to use these, and so they would not recommend them. So this is the status in the U.S. So from our point of view, choosing a procedure as to manage this is related to tissue vaporization versus coagulation necrosis. And we talked a bit about this last night. And Dr. Sullivan would remember, and I remember, the VLAP procedure. And so the VLAP procedure used a neodymium YAG laser, and the problem was that it was, as we talked about last night, it causes a deep coagulation necrosis and was associated with frequency urgency dysuria syndrome. What you really want is vaporization, and vaporization occurs when the cells are boiled to great, so they have to get over 100 cc's. There's actually boiling, it forms a steam. As we saw last night, there was a lot of vaporization bubbles coming off the tissue, and that's really what you want to see. So the key is vaporization. If you get vaporization plus coagulation, it becomes more difficult because the electrical resistance of the tissue increases and you can't penetrate through and get it vaporized. So each of the lasers that are used for treatment of prostate and other things, mainly stones, has a different characteristic. Whereas the KTP laser, which for the residents, it's actually a neodymium YAG laser with a crystal in front of it which changes the wavelength, cuts the wavelength in half, whereas a holmium laser is a YAG laser that actually doubles the wavelength. So if you think of them in terms of tissue, we've got a 0.8 millimeter penetration with the KTP, but that 0.8 millimeters is vaporized. So the tissue, even though it's only penetrating a bit, it's vaporizing that tissue, then it's penetrating the next level and the next level. So it has a very thin layer of coagulation necrosis. Similarly, the holmium as well. Holmium is absorbed by water, and so holmium tends to not have as deep a penetration, but it also has a fairly minimal zone of coagulation necrosis, whereas the YAG, of course, has this deep penetration causing coagulation necrosis. So all this is great, but why don't we just stick with TURP? I mean, TURP is a very good operation. It's stood the test of time since introduction in the 30s. We've seen modifications in technology which have improved it, but what can we do better about TURP? Well, there's a very good review in European Urology by Rasweiler, which is very good for the residents to just take a look at, because it tells you all about the potential problems with TURP, and it gives you some real numbers, because we talked yesterday about some numbers in terms of erectile dysfunction. So that paper is very good to review. But if we look at what about TURP? So TURP was inpatient. If you're in a teaching hospital, particularly it's an inpatient procedure. 1.8 days at our institution for stay. Transfusion rate 3% in the paper by Oliver Reich, which is in European Urology as well. And I think that may be an underestimate in a teaching center. In a teaching center, what we're seeing now is a lot of patients in urinary retention. Their prostates are bigger and bigger. And I think that our transfusion rates are actually much higher than this when a resident gets in deep resecting a 100-gram prostate. I think it's difficult to control the bleeding. So bleeding still is an issue. There is some pain associated with the procedure. We have urethral strictures and bladder neck contractures. In the Reich paper, surprisingly, the retreatment rate was 6.8% at 30 months, which I thought was quite high, but maybe that is what we actually see. There's issues in terms of erectile dysfunction and certainly retrograde ejaculation, and we still see hyponatremia, glycine toxicity sometimes with these big glands. And the other thing about TURP is it's not universally applicable to the patient who's either anticoagulated or is a very high risk from a cardiac perspective.
I noticed you've taken back reading.
Yes, certainly, yeah, no question.
One of the advantages of laser, I think, is you don't get the fluid back.
Yeah, you don't get the extravasation, you're right. It's not done with the same pressures. So people came up with different options in terms of procedures, and I've mentioned tuna and microwave and interstitial laser that really there's no data whatsoever to support them. I'm just going to comment on a couple that are used in Canada. With HOLAP, there's actually only one randomized controlled trial, which is electrovaporization versus HOLAP, and basically showed no difference in symptom scores or flow rates at 6 months. They showed that it was a longer OR time, and there are no randomized controlled trials with TURP or even matched cohort studies with the HOLAP. So the HOLAP is basically a vaporization technique using the holmium laser. And the nice thing about using that, of course, is that we all have a holmium laser, but unfortunately the physics of the texture of the tissue and the absorption of it doesn't really result in a very good procedure. It's a prolonged procedure, still having that problem with the dysuria. Now the procedure that actually does have excellent results is HOLAP. So HOLAP, there's been 4 randomized controlled trials, and they were actually taken as a meta-analysis and reviewed. And when it was looked at, the urinary scores, change in IPSS and change in flows, are actually better than TURP. So there's less transfusion, especially when they looked at the very large prostates, less transfusion, less hospitalization, and a shorter catheterization than TURP. So HOLAP actually has excellent results, but the problem has been that the procedure is difficult to learn, and so it hasn't really been generalizable. And so there's people like Dr. Patterson and Dr. Al-Halali who've made it work for themselves, but unfortunately it hasn't really been something which has been generalizable to community urologists and other individuals. So when we were designing this study, Dr. Klaus Rohrbrunn has talked about problems in the BPH literature and what are the flaws in the BPH literature. And when you look at it, almost all of the studies are small. They're usually industry sponsored. It's very difficult to blind because you can't really blind the patient. You know, if you've done a laser procedure and they're told to go home versus if they've had a TURP and they're staying in the hospital and they've got a red bag at the end of their bed, it's pretty difficult to blind the physician or to blind the patient. The big problem in the Boucher-Haze study in Australia was withdrawal. The patients will sit and listen to you, and with the way we have to do consents these days for trials, you have to disclose the other arm, and as soon as they read the other arm, they're like, okay, I'm out of here, if they randomize to TURP. And that was the big problem in Australia, because basically what they were doing was that if they signed up for the Greenlight, they got a free operation, and as soon as they randomized to the TURP, they were out of there and they went down the street and bought their Greenlight. So that is a real problem in doing any surgical trials. The other thing that's been a problem is durability. Looking at so most of the trials, because they're industry sponsored, they're expensive to do, so there's short follow-up, 3 or 6 months. And we're also chasing a changing gold standard, because TURP changes as we change coagulation.
Well, can I ask, so why is it usually sponsored, why is industry sponsored under FLAWS?
Just that there's a bias created by the industry sponsoring the trial itself.
There's no bias by the investigators leading the studies?
Yes, yeah, no, for sure. But there hasn't been any studies which actually have been done by granting agencies of any size, so that to try and take out that bias. But I think there are certain pressures which are applied when you're doing it for an industry individual. But I can certainly see your point. So I've talked a little bit about the physics already. I'm not going to go through that anymore. So in summary, what happened with the assessment by the Ministry of Health was they said, could we save bed days? So they said, yes, we could save 10,000 bed days in the province of Ontario. We could offer a less invasive treatment, and because we could offer a less invasive treatment, maybe people would not choose medical therapy. They'd be more likely to choose surgical therapy. That's going to cut our costs, and it's also going to result in individuals not having to double pay, going on 10 years of combination therapy and still having a TURP at the end of it. They also echoed what Dr. Warburton said in terms of the quality of studies. They did not feel that there was adequate studies, and there wasn't enough long-term follow-up. And so what they did was then allowed us to go ahead with our procedure. I just want to comment a little bit about the literature, what's in the literature to date. So the Bucher-Haze randomized trial I'm going to cover in a second. There is this large series from Ruzak and Bachmann in Switzerland. It's just basically a large case series. The interesting thing about their case series is that about 30% of the patients they treated were fully anticoagulated. In Switzerland, apparently, if you get old, you get anticoagulated. So they have an incredible experience with doing anticoagulated patients. The Greenlight Users Group data is a series of experts put together their trials, not really trials, put together their experience. So it's not really valuable information in that it's just pooled data from a group of experts doing a procedure. The Al-Ansari paper caused a lot of roar. This is from Qatar, and this was actually a randomized controlled trial looking at TURP versus Greenlight HPS. And what they found was that there was a higher retreatment rate in the Greenlight arm. And when you cone down and actually look at what they did, all of the retreatments were in patients who had glands 80 cc's and above, and it was the first time they'd ever actually had a Greenlight in their hands. So what it proved, in fact, was that if you're just starting out doing Greenlight, don't do glands over 80 grams. The other thing that was interesting was they were just starting to do TURP as well, and they had a 25% transfusion rate in the TURP arm. So the trial's a little bit questionable. There's a new trial from Kaplan just came out last month's European Urology, and it's very similar to our trial actually in terms of it's a non-randomized prospective trial looking at HPS versus TURP, and will show similar data to what I'm going to show you this morning. As far as sexual dysfunction after TURP, we talked a lot about that yesterday with the residents, and there's a significant question as to whether or not TURP actually causes sexual dysfunction. In the Bucher-Haze data, you can actually see that both groups did not show any change in their Shim scores before and after their procedure. So I think there's becoming increasing controversy as to whether sexual dysfunction actually is improved or worsened with prostate procedures for benign disease. So Luke Cavusi's, I think this is his exiled brother. This is Dr. Cavusi from San Antonio. He actually did a trial looking at sexual dysfunction after Greenlight and showed no difference in the pre- and post-operative scores for sexual function. Now, Briere in Lyon, France, actually did show significant change in patients after Greenlight, and what they did was they coned down on a very small subsection, and what they found was that the patients who had absolutely normal sexual function going into the procedure tended to be the ones where there was a change in their overall sexual function, but the change was about 5 points, and they were questioned whether the patients actually would perceive that or not. So I think the jury's still out as to whether, if you read Campbell's, it says that there's a 5% loss of erections with TURP, but I think it's much more complicated than that, and I'm going to show you our data and what happened with ours. Now, in the actual Busher-Haze trial, this is a randomized trial of TURP versus PVP, which now has 2-year data. Both show a very good increase in flow rates, IPSS changes. There's no difference in the Shim scores pre and post-op, but note that that's in both arms. The length of stay, they actually kept the Greenlight patients in hospital, and obviously it's less for the Greenlights. The length of catheterization is significantly less, and there was basically minimal change in the hemoglobins. And again, this data has now actually been looked at in a 2-year follow-up, and it seems to be durable. So our study is a multi-institutional, non-randomized, non-blinded trial, and it was completed at 3 hospitals, 2 community hospitals and our academic hospital, with a contemporary matched cohort of TURP patients. The primary endpoint is change in IPSS at 6 months post-op, and there are a series of secondary endpoints, including resource utilization and costing, which I'll also give you this morning. And we were funded to follow out the durability to 2 years. And what we're doing there is we're actually doing telephone calls, and we do an IPSS over the phone, which is not really valid because, as you know, the IPSS is to be a self-administered evaluation of symptoms.
But who were the institutions? Were they all residency-trained institutions?
No, there were 2 community hospitals. There was Scarborough, Mississauga, and then our place. And in our place, I had to contract that I had to do all the surgery. So there was no resident participation in actually doing the procedures. Now the demographics, basically they're matched. The slide, I have all the demographics, but basically the only difference is that the TURP arm is older, and the implication there was that in the TURP arm there were very few people who were working full-time, so it affected our analysis in terms of work. And so consequently, we don't have very good data on work in the TURP arm. And you can also see that the numbers in the TURP arm are fairly small. And again, it had to do with this, that once they read the consent, everybody wanted to get in the Greenlight arm. And so this is a problem with doing an open, non-randomized trial. So the primary endpoint is IPSS, changes at 6 months. And you can see both arms have a significant decrease in the IPSS of about 15 points. Not really any difference between the 2 groups. If the frequency urgency dysuria syndrome was a real thing, what we should see is at the 1-month follow-up, there should be a peak up on the PVP thing because it should be reflected in the frequency urgency questions. So in the frequency question, if you look at it, you can see that there's really no difference at the 1-month mark in terms of the PVP or TURP group. So I don't think we're seeing the frequency urgency dysuria syndrome. Flow rates, no difference between the 2 groups at the 6-month mark, about a 9 cc increase in overall flow rates, and no difference between the 2 groups. Post-void residual urine, there is a statistically significant but clinically insignificant difference in favor of PVP, but I basically would say that this is the same. Now the Shim scores, this is a little bit more complex. If you look at this just as a simple graph, you can say that the Shim scores before and after are the same in the 2 groups. The TURP group has a lower initial score, I think reflecting the change in age. But to say that there is no change in sexual function with either of these procedures simplifies this slide, I think, too much. So 40% of the patients were on 5 ARIs before they went into the trial. And I think when you take a group of patients who come off 5 ARIs for 6 months, there should be an improvement in their sexual function. There also should be a subset of the patients who undergo prostate surgery who actually get improvement in sexual function afterwards, and that's Valencien's work. Valencien has shown that patients who have treatment for avoiding dysfunction have improvement in their sexual function. So I think buried in here somewhere there is actually a group of patients where there is a decrease in the quality of sexual function by both of these procedures, and we actually have a paper at the AUA this year which we've submitted to the AUA this year, which actually dissects this out a little bit more and tries to give us a little bit more information. Now this is the EQ5D data, just looking at quality of life. So when the statisticians looked at this, they were all excited because there was a 0.05 increase in quality of life in the PVP arm, and they said that was quite remarkable because when you have coronary artery bypass grafting for chest pain, you have a 0.03 increase in your EQ5D. So there's really a significant improvement in both arms, but particularly in the Greenlight arm, there seems to be this improvement in quality of life. Now, as a surrogate for effectiveness of these procedures, a lot of people use PSA. So what we did was we took out the patients who had been on 5 ARIs, and we looked at the drop in PSA in both of the two groups. Now, Dr. Alivazatos from Greece has looked at this, and in Alivazatos' randomized controlled trial, he did a trial of open prostatectomy versus Greenlight, and what he found was that he had a 50% reduction in the PSA value in his Greenlight arm, and he had a slightly higher drop in PSA with the open prostatectomy. Basically, the PSAs went down to 10% of what they had been, but he had a 50% reduction in the Greenlight arm. Now, we didn't get as much of a reduction, which I think reflects the fact that about 70% of the cases were done by people who were actually on the learning curve for Greenlight, including myself. And so I think that's why we don't see as much of a PSA reduction as Alivazatos. But what people really look for is a 50% reduction, and that's what probably we should see with our next set of data. Now, the postoperative results, we showed that there was that PVP took longer. I mentioned last night with XPS, with the next laser, I'm finding that these times are actually coming out relatively equal. The post-op hemoglobins, the mean preoperative hemoglobin was 141, so the PVP didn't change at all. There is a drop in the TURP group, but one could argue whether that's clinically significant or not, because it's not necessarily going to change the patient. We were able to do 127 out of 132 as outpatients, and if you were admitted, your mean length of stay was 1.2 days, whereas the length of stay for TURP was 2.4 days. If we focus just on the PVP cohort, the patients, for some reason, there's something a bit different about the procedure. There were only 4 catheter reinsertions, so the patients seemed to void without difficulty. All the catheters were taken out the next morning. There were 7 patients who were readmitted over 6 months, but not all of those readmissions are for urologic problems. There were 2 patients who had TURP at 24 months. We had a nice drop in the nocturia from 3.9 to 1.6. We had 6 cases of urinary tract infection by the end of the first month, but only 1 from months 2 to 6. No patients were discharged with narcotic pain medication. We send them home with nothing, and basically we've continued that. We give a 1-dose perioperative antibiotic. We don't send them home with antibiotics or pain medication, and they come back the next morning and have their catheter out. 46% of the patients had antegrade ejaculation. And this is in a non-validated questionnaire that we developed. And since that time, there is a validated questionnaire for antegrade ejaculation now. But the rates that have been quoted in other series are not as high as this. They're generally around 35% of the patients maintain antegrade ejaculation after a PVP procedure. Looking at societal and caregiver impact, 49 of the patients in the PVP group had full-time employment, and they took a total of 408 days off work, or a mean of 8.35 days. The median number of days was 3, and 15 of the patients actually took no time off work at all. There was only 32 days off work total for caregivers. And when we looked at resource utilization, in other words, going to your family doctor, going to the emergency department, having tests done, etc., resource utilization for health issues was totally equal between the two groups. We then went to cost out. How much is a TURP, and how much is a Greenlight? So the total cost for a TURP, in terms of the best costing we could do, was $4,561. The cost for a Greenlight came out at $3,187, and that includes capitalizing in the cost of the laser over 5 years, and that's what the calculation at the bottom is. So there's an initial sort of first pass. It looks like there's about a $1,500 difference between the two cases, or $1,400 difference between the two cases. What we then did was we went back and we put in all the physician admissions, the extra procedures, the redo procedures, catheterizations, etc. And we took in the cost of those, and we also added in the cost of the time off work. And of course, the problem is that in the TURP group, there was nobody taking time off work, so it is weighted against the PVP group, because there's a third of those patients actually had time off work, so we calculated their cost of time off work. So when you look at that, and you do quality adjusted life years, you can see that there's still the cost difference is still in favor of PVP. The quality adjusted life years is in favor of PVP, and when you put those two together, it shows dominance for PVP in terms of its costing. We then did a cost effectiveness plane and cost effectiveness acceptability curve, and what you want to see if you're doing a procedure is you want to be down in this quadrant down here, because this quadrant shows that you're improving quality of life years at a lower cost. So that's the optimal to be in that. Now the scatter plot, what it is we created a model for our costing, and then what we did was varied the frequency of adverse events up and down in the group, and then did the scatter plot. So there's 1,000 runs of the model, which actually show that it scatters in this lower cost with higher quality of life for the Greenlight. Now our trial, the limitations of it, it's non-randomized. We had a small cohort of TURP patients, but they are contemporary and they are balanced. The resource utilization and costing data is strictly for the province of Ontario, so it may not match other jurisdictions. Now our conclusions, and what we're going to actually talk to the ministry about, is that Greenlight provides outpatient treatment of lower urinary tract infections, lower urinary tract symptoms with similar outcomes to TURP. It takes a bit longer. We think that's going to be impacted on by the new laser. No change in hemoglobin. It's outpatient. Quality of life was improved in both groups, but particularly in the PVP group, and that there was a minimal impact on employment and caregivers. So since we have a few more minutes, I just wanted to talk about some special things that are special to groups that you might be involved in because of the fact that you're at a teaching center. So specifically, how about can you teach people to do this? On the AUA website, it still says that residents are supposed to do 80 TURPs in their residency program. I think that's hard to meet given the emphasis on medical therapy. So how long does it take you to actually learn how to do a Greenlight? So our residents now routinely do Greenlights, and what I find is after about 10 cases, they do a very good job of their half of the procedure, as long as it's a relatively small gland. But if you take a community urologist with a lot of experience doing TURPs, what I usually do is have them come and watch me do it one day, and then I go to their hospital and do the first 5 cases with them. And at the end of that day, they're doing 30 to 50 cc glands with very good results. And so I think that this is easier to teach residents, and it's also quite easy to teach to community urologists, as long as one stays within the parameters of working on small glands without big median lobes to start, and then moving oneself forward. Now the residents love doing these because they get to do the operation. If they start whacking away at a 100-gram TURP, very soon it's a bloodbath, and you're circling the table faster and faster and faster, and eventually you just take over and finish it. So they really like doing these because of the fact that they get to do the operation. And with XPS, it moves so quickly. I showed some videotape of cases last night. It's really fun, actually. So we see the residents are actually big fans of PVP, but the biggest fans are the recovery room nurses, because they don't have to syringe and fiddle and with our cases. So now, how about large prostates? Can you do large prostates? So the first study was by Kaplan's group, and they did prostates which were over 100, and they went up to 120 cc's, and they showed that they could do it, but it took a long time to do the procedure. Wu with the HPS presented his data in that European Urology supplement, and it showed that they had a lot of irritative symptoms if they were doing really large glands, but that the patients really did very well in the long term. Alivazatos, he did relatively large prostates. It was a randomized trial with open prostatectomy. The mean size of the gland was 93 cc's, and he had excellent outcomes. And then I've mentioned the Al-Ansari paper, which showed that if you're brand new to doing this, don't do really big prostates. This is our data, subset analysis of our data of prostates over 80 cc's. And the only difference between this and the overall data is that the Qmax is not quite as high in the patients who had the large glands. So the changes in Qmax are slightly different, but it's really only a couple cc's. So we were able to complete the large prostates, but again, having moved forward with XPS, I'm finding now, like I showed last night, I showed 2 100 grams and a 200-gram prostate, and those were completed within a reasonable time frame, so I think it does work well.
Well, how were the gland sizes quantified?
Transrectal ultrasound. And then what about the high-risk patients? I think this is a huge advantage for some of these procedures. Certainly for Greenlight, Sandhu and Kaplan again presented the first group of patients who were fully anticoagulated. Wu had a paper, and then the Ruzat paper from Switzerland with over 200 patients that they did fully anticoagulated. And what you find is that it doesn't really bleed that much at the time. I keep all those patients in hospital overnight. They go home the next morning, and when they tend to show up in the emerges 3 weeks later when the slough falls off, they get a bit of a bleed. They might end up with irrigation, they might not. And they usually go home. The resident just usually irrigates them out and sends them home. And it's about 20%. So if 20% of the patients end up with a bit of an irrigation at 3 weeks, but they end up with a minimally invasive, bloodless, painless procedure in a fully anticoagulated patient, I think it's a good balance, and I think this is one of the major advantages of this procedure.